Welcome to this clinical explainer. Today we're unpacking a medical puzzle that is honestly, truly bizarre, but absolutely fascinating. Picture this. A 16-year-old female patient arrives at the emergency department. She's got a 4-month history of just feeling totally full right after eating, early satiety, some pretty vague epigastric distress, and she's lost about 8 kilograms. Well, you examine her and you feel this firm, completely non-tender, J-shaped mass in her abdomen. It literally feels like it perfectly matches the contour of her stomach. Oh, and you also notice alopecia areata, patchy hair loss on her scalp. So the endoscopist goes in to retrieve what looks like this jet black, foul-smelling mass. But their snares, they just repeatedly slip right off. Even blasting it with powerful water jets completely fails to break the thing apart. It's essentially indestructible.
So you really have to ask yourself, right? Why does this happen? Why does a mass of hair resist months, or honestly sometimes even years, of digestion in a highly acidic stomach environment? We're talking a pH that sits right between 1.5 and 2.0. Well, the answer lies in the incredible biochemical resilience of human hair. You see, hair is primarily made of alpha keratin, and it's held together by these super dense disulfide bonds. Those bonds make it practically immune to proteolytic enzymes like pepsin and totally resistant to concentrated hydrochloric acid. Add to that a hydrophobic lipid cuticle layer that actively repels enzymatic wetting, plus a thick coating of entrapped gastric mucus and, decomposing food. What you get is quite literally a biological drain clog. The stomach's natural peristalsis just can't grip those smooth hair fibers to push them out, so they tangle into a massive fibrous mesh, eventually taking on the exact shape of the gastric cavity.
Okay, let's dive into this. Here is our clinical roadmap for today. We'll start with symptoms and signs, move into diagnostics, look at treatment options, hit some key clinical points, and finally, wrap up with our references.
Let's jump right into Section 1, Symptoms and Clinical Signs.
First things first, we need to clearly define exactly what we are looking at here. A standard trichobezoar is a mass of ingested hair that is trapped entirely within the stomach. But when that mass develops a tail that extends past the pylorus and snakes its way all the way down into the duodenum, the jejunum, or even the terminal ileum, well, that's what we call Rapunzel Syndrome. This is a rare and absolutely life-threatening variant. The mechanical tension from that tail can cause some severe downstream effects. We're talking intestinal obstruction, traction-induced mucosal ischemia, pressure necrosis, and eventually, if left untreated, bowel perforation.
Now, as for how these patients present, and it's worth noting that over 90% of them are young females, they'll often come in with progressive postprandial fullness, really significant weight loss, and epigastric distress. But the two massive red flags on your physical exam, first, the alopecia areata on the scalp. That is a huge clinical clue for trichotillomania, which is compulsive hair pulling. And second, that palpable J-shaped mass in the epigastrium. Remember, it's J-shaped for a reason. Over months or years, that hair concretion has literally molded itself to fit the exact internal dimensions of the patient's stomach. Moving on to Section 2, Diagnostic Modalities.
So there is actually a pretty stark contrast between a trichobezoar and its plant-based cousin, the phytobezoar. A phytobezoar is basically a concretion of undigested plant fibers, things like cellulose and lignin. Because of their chemical makeup, phytobezoars can actually often be broken down using chemical dissolution. Believe it or not, you can literally irrigate the stomach with Coca-Cola to dissolve a phytobezoar mass. But as we learned a minute ago about those incredibly tough alpha-keratin disulfide bonds, chemical dissolution is completely useless on human hair. For a trichobezoar, you are almost universally looking at a surgical approach.
And this brilliantly illustrates our high-yield diagnostic differential when we're evaluating a gastric mass. If you're dealing with a gastric gist, your CT will typically show a hypervascular mass, and endoscopy will reveal an intact overlying mucosa. Gastric adenocarcinoma, well, that generally presents in an older demographic with focal wall thickening. And a pancreatic pseudocyst will show up as a fluid-filled lesion closely linked to a history of pancreatitis. But our trichobezoar, it totally stands out. It's got that firm J-shaped presentation, usually a history of trichophagia, which is the actual swallowing of the hair, and very distinct imaging characteristics.
Which brings us right to the imaging. Now, while upper GI endoscopy is incredibly useful for visually confirming that, yes, there is indeed a massive ball of dark hair sitting in the stomach, it's a total diagnostic trap if you try to use it for treatment. The absolute gold standard for diagnosis and staging is a contrast-enhanced CT scan of the abdomen and pelvis. What you are specifically looking for is a well-circumscribed, non-enhancing intraluminal mass that features what radiologists call a mottled gas pattern or a sweeping rim of air. And the CT scan is absolutely critical here because it tells you exactly how far that tail extends down the GI tract. That's how you confirm if you're dealing with a standard trichobezoar or a full-blown Rapunzel syndrome.
Let's shift gears to Section 3, surgical and psychiatric treatment.
All right, let's walk step by step through the surgical management protocol. First up, you need preoperative stabilization with a nasogastric tube for decompression. Next is surgical access. Usually you're looking at an open upper midline laparotomy for those really large masses, and it is crucial to isolate the stomach with moist lap sponges to prevent any peritoneal contamination. Then comes the anterior gastrotomy to carefully deliver the massive bezoar in a single piece. But wait, you might be wondering, why not just use an endoscope? Well, the data shows endoscopy has a greater than 95% failure rate for large trichobezoars. Attempting to force a massive rock-solid hairball up through the lower esophageal sphincter can easily cause an esophageal rupture. And trust me, you do not want to instantly turn a controlled abdominal surgery into a catastrophic thoracic emergency.
So, the absolutely crucial point here is step number 4, full small bowel exploration. Picture this. It's 2 a.m. in the OR. You've just successfully pulled this giant foul-smelling mass out of the stomach. You might be incredibly tempted to just close up and call it a night. Don't. You must run the entire length of the small intestine, starting from the ligament of Treitz all the way down to the ileocecal valve. If you fail to find and remove fragmented satellite bezoars or a broken-off tail, your patient is going to bounce right back to the emergency room 48 hours later with a severe post-op small bowel obstruction.
But here's the reality check. A flawless surgery doesn't cure the underlying disease. When we compare the surgical and psychiatric guidelines side by side, it becomes super clear. Yes, surgery fixes the acute mechanical threat, but if the patient's underlying trichotillomania goes unaddressed, they will simply swallow more hair and that bezoar will come right back. This is exactly why an inpatient psychiatric consultation prior to discharge is completely mandatory. The first-line psychiatric therapy involves cognitive behavioral therapy alongside habit reversal training. And on the pharmacotherapy side, medications like SSRIs or N-acetylcysteine or NAC are often used to help manage the severe impulse control disorders that are actually driving the behavior.
Next up, Section 4, key clinical points.
The source literature actually gives us a few high-yield takeaways that are absolutely fascinating to keep in mind at the bedside. First is the halitosis clue. If you have a young female patient presenting with an unexplained epigastric mass, scalp alopecia, and just severe putrid breath that smells like rotting organic matter, suspect a trichobezoar immediately. Second pearl, which we've hammered home, never force endoscopic removal. Third, when you're in surgery extracting a Rapunzel Syndrome tail, it requires a very, very gentle touch. If you meet resistance and pull too hard, you can actually avulse the mesenteric border of the intestine. And finally, always check the patient's hemogram. That massive hairball causes chronic mucosal pressure, which leads to slow, silent blood loss. That results in microcytic anemia, as well as significant malabsorption issues like a B12 deficiency.
And finally, Section 5, references.
So, just to be clear, everything we've discussed in this explainer is grounded in robust clinical data. For instance, the Gorder study from 2010, that's the landmark paper that proved a 100% surgical success rate compared to that dismal sub-5% endoscopic success rate for trichobezoars. The NICE guidelines establish the strict evidence base we use for CBT and habit reversal training. The American Journal of Gastroenterology dictates our exact surgical indications over using chemical dissolution. And Dr. Nike's 2007 paper, that remains the definitive standard for precisely defining the anatomical extensions of Rapunzel syndrome.
I want to leave you with a provocative thought as we wrap up this explainer. We've clearly established that while we have truly mastered the mechanical, surgical extraction of these massive trichobezoars, a scalpel simply cannot cure a psychological impulse. If discharging a physically healed patient without psychiatric support essentially guarantees a recurrence down the line, how do we systematically integrate deep, immediate psychological care right into our fast-paced emergency and trauma settings? It's a profound question about holistic patient care, one that really challenges the boundaries of modern medicine. Thanks for joining me on this deep dive today, and keep asking the big questions.